Yeah. Wonderful. So I invite the speakers from this session to come on down and start taking questions. Please write your questions on the card, pass them to the end so we can bring them down here. I'll start with the first question to Dr. Lin. Dr. Lin, so kind of integrating the different things that we heard, it's not uncommon to see a patient that you might have operated on years ago, and then their PSA begins to rise, so they have a biochemical recurrence, but that level is still very, very low, like say 0.2 or 0.5. We know that conventional imaging, a CT scan or bone scan, won't identify where that cancer is. But some of these new PET-based imaging, you can see, for example, a lymph node that lights up there. So you're thinking, and maybe your own experience as well as nationally, if you go in and try to treat that single spot, surgically removing it or radiating it, kind of what's your thought process for when you might do that, and so far maybe what the success rates have been, considering maybe it has spread to other places microscopically that don't even show up on that PET scan?
Yeah, it's a great question, and this really plays into basically all the talks today. Specifically, the really great imaging talk that you heard, we can use these newer PET scans to find a node that we might do a CT scan, a bone scan, it might look clear, but the PSA is going up. Where is it? The PSA is still less than 1. We can do some of these scans. We sometimes find a spot or more than one spot. Usually it's less than 5. And we have either gone in, and I have gone in and surgically removed those, or radiation colleagues have used radiation technology to zap that area. And in general, I'll tell you our experience, just really briefly to keep it short, is that the PSA always goes down. Now, does it stay down forever? No, not usually. There have been some patients where we've gone in and either I've taken them out surgically, or one of my colleagues, or radiation experts have given radiation, and it has gone down to undetectable, like less than undetectable limits, and then stayed that way. But most of them do recur. What I think it does is sort of reset the clock. So instead of having this rising PSA and then eventually having to get hormonal treatment, maybe it resets the clock a couple years, and that's what we think.
Great. For Dr. Matesan, what's the difference between Axumin PET and a regular CT scan?
So
maybe just PET in general and a regular CT scan.
So CT scan, like in general, CT gives the anatomic images, and then you kind of rely more on the size of the lymph node, that it's abnormal or not, or a new finding. But PET, it gives you functional images, so how it's a molecule process, if it's increased processing of that biomarker in a cell or not. So I think they are kind of complementary, CT and PET, but PET had great improvement lately for prostate cancer. I'm not sure what's the question.
Okay. So Dr. True and Dr. Reeder, the standard number of, and maybe Dr. Land, the standard number of cores seems to be 12, but a question is, prostates are different sizes, right? So maybe shouldn't you be doing, more biopsies in larger prostates, perhaps fewer number of biopsies in smaller prostates? And then a corollary question is, Dr. Reeder, do you ever go back and re-examine Gleason grading? In other words, somebody had a biopsy 5 years ago. Do you ever go back and reinterpret that grade?
I'm pretty sure I'm not the person to answer that first question about the number of biopsies and the size of the prostate. Dan, that's probably your.
Yeah, I think it makes sense. You have a prostate gland that you're placing 12 needles in. If it's a big prostate gland, you're going to just by definition sample less of the gland. I think that is true. In general, we'd like to sample the whole gland. I think the real answer to that question is we've been using more MRI. So MRI is really on the rise. If we do an MRI and we see a lesion, we can use this technology called MRI fusion to really target that lesion within a millimeter. And so I think that's really the future, is using MRI for bigger prostates. For smaller prostates, we get a good sampling with just 12 biopsies. I think a very, very good sampling.
And whoever asked the second question, I thought I was really clever, thought for months about the best way to do a study. We just got funded by the DoD, and I guess in 5 minutes you thought of the exact same study. So we're going to go back with active surveillance patients who had radical prostatectomies, part of the Canary Pass study. We're going to go back and look at their archived tissue, take biopsies of those wax blocks we made of the tissue, do our light sheet microscopy, compare to standard pathology, and try and see, can we better predict who had biochemical recurrence years down the road? So we think that's the best way to examine whether our technique works.
Great. So what is the advantage, or is there any known data discriminating PSMA PET from Axumin PET, or possibly even choline PET? Is one known to be better than the other at this point in identifying prostate cancer recurrence, for example? And when will Seattle have PSMA PET?
So there are a couple of questions. So there is a study that compared carbon-11 choline with fluocyclovine, Axumin, and Axumin did much better than choline. And there are not just only one study that comparing fluocyclovine with PSMA, and there are only 10 patients, and the scanning is 2 months interval. So the patient received PSMA study 2 months after fluocyclovine, and PSMA did better than the fluocyclovine. And that's about the comparison. And when we are going to have PSMA, so it's like there are a couple centers that are doing as like IND approval drugs, investigational drug, and then I talked to Dr. Graham at the University of Iowa, and he said they will submit probably in the next 1 to 3 years to seek approval for this trace. As of right now, it's just clinical trials. Can't hear you. As of right now, it's just clinical trials. They are 8 centers that are doing clinical trials, and they will gather the data and send it for approval, but probably in the next 3 years or so. So it will be a while.
Yeah, I can just say real quickly, PSMA PET is an FDA issue. I mean, take it to the government. It's very difficult to get an IND, investigation of a new drug. It's really having an issue in this country, okay? It's available. I think we have Axumin. Axumin looks like it's incredibly good. There's some benefits to that, too. It's not urinary excreted, so the bladder doesn't get in the way. We have that immediately available here in Seattle. We're leading the way and doing some amazing studies. Evan, you, I think, might have some data on that this afternoon. So,
great. Dr. Zeng, what's better, IMRT versus proton therapy? Perhaps we're talking about localized prostate cancer treatment.
That's a good question. It also depends on what you mean by the word better, because I think that means different things to different people. Your insurance company sure will define the word better different than you will. So I think we think, proton radiation is better than IMRT to different degrees for different groups of patients, if that makes any sense at all. Meaning that, we admit that the group of patients we're most excited about treating at the Proton Center are children, actually, because we know that with proton radiation, we get to give less radiation to your body. Now, if you think back to the image that I showed, when you're talking about treating something down your pelvis where your prostate is, you don't have a lot of critical organs kind of in the soft tissue in front of and behind in your abdomen. Most of us is just varying amounts of skin, fat, and muscle. Whereas there are other situations where you're treating the brain, treating the liver, treating the spine, you have a lot of very critical organs that are in that area that proton therapy can help spare. And so, what insurance companies will often ask is, fine, you can show me on a piece of paper that you're giving less radiation to the body, but you need to prove to me in a randomized clinical trial that that means less side effects for patients, which is a fair statement. And so those clinical trials have never been done before, and it's in the process of being done. We have it open at our center. But when you're doing a clinical trial, you need time in order to kind of accrue patients onto it and then follow them. We're happy that for prostate cancer, you guys live for a really long time, but that means that, we need results years down the road. No one respects 1-year results in prostate cancer. They want to see 5, 10-year results. So those results won't be available for years to come. In the meantime, patients rightfully have very strong feelings about what kind of treatment they want, so they don't want to be randomized on a clinical trial where a computer tells you what you're going to get. You want to choose yourself what you're going to get. And also, insurance companies, if they say you can't prove a benefit, so we won't cover it, if you won't cover it, then the patient can't go on the trial to generate the data that will prove that it's beneficial. You're kind of in a little loop by itself. And so, and I apologize, I've actually forgotten the initial question. Which one is better, protons versus IMRT?
It's like, which is better?
I think what I typically say is if everyone had insurance coverage and lived across the street, I'd get protons. But, if you live 3 hours away and you don't have insurance coverage, I think that's a, more personal question. So.
Great. So there's a lot of questions about immune therapy. We're going to address those this afternoon in the sessions, so we're going to hold on those. I want to give you plenty of time for lunch, so we've got 45 minutes scheduled. There's box lunches. If we didn't answer your question here, come down and grab these guys right now before they get their